some of them are non-lesion, as you can see the figures here. Then for the data sets, for the test data sets, this is the amount, and then we have this amount. So the next thing we did was to split this test and train data set into 80% train and 20% validation, and we made some other insights about the images in the data set. We observed that some of those images are low, some of them have high resolution, and some of them look alike. And in some of them, we have some that are, if you consider the effect of the brightness, some are blank, as you can see here. And most important thing is this: we have the label, which is the bounding box of the lesions. They have size variations; they are not of the same size. So with this information, the next thing we have to do is to provide a model that can handle this data set based on this observation that we made. And of course, we looked at various models, and we found out that YOLO can actually do these two types of versions, can do this, YOLO V9 and YOLO V8, and I'll tell you the reason why. We have, for this model, we have the architecture of YOLO V8 and V9 is this. We have the backbone which extracts the features, and the leg which for those features that were extracted, it focuses and tries to enhance those features, and the head tries to do the classification and detection and classification. So among these stages, at the head, these two versions can actually consider these size variations, and of course here it can work with small lesion detection. Here is the medium, and here can have a higher bounding box. So with this reason, we also looked at, and of course these are what is called couple head, like finding the lesions in sizes. So we didn't go for YOLO V9 because of the computational resources we have. Our systems can handle that for long, and YOLO V8 is faster, so we went for the one that we can handle it. So and also we, after determining the model to work with, we try to use the pre-trained model and fine-tune the hyperparameters of that YOLO V8 and pre-trained model, like the learning rates. We use 70 people, though we have many trials, but the one that gave us the best one is the one I'm presenting. So we use 70 people, and the image size from what was provided from the challenge is around 1,000 to 1,000 something. So we use, by default, YOLO uses 670 something image size. So we use 1,024 size of image for that. And also along the line, we noticed that YOLO by default, when going for the boss game, YOLO by default focuses lay more emphasis on the bounding box, and for each of the images, there might be some areas where this lesion might be detected, but based on the fact that we have provided the bounding box, YOLO will just focus on that. So what we did is to work on the boss game to try to vary it to get YOLO to be able to detect those lesions that does not contain the bounding box. So we trained the model, and this is the results from the confusion matrix. As we can see, we have about 3,500 or 3,470 images that the model predicted as lesions, which are actually lesions, and we have about 1,600 of them that the model is saying that this is not lesion, but meanwhile they are lesions, which is very bad, because for this kind of scenario, we are concentrating more. We don't want to miss a patient with lesions, while our model is predicting that they are not lesions. And of course, the other false positive we are having is that the model is predicting that they are lesions, meanwhile they are not. So we need to actually work on this false negative and false positive to have more detections. So moving on, the result we obtained, and of course, this was our boss loss for training and validation, and also the NLP that we got. So the first result we got from the test was 66% with the best model. Then we considered how the IOU and the confidence the model has, how it is behaving with this, how it is behaving to give us this 66%. So we decided to have less overlapping of this ground truth that was actually detected. So we tried to tweak those IOU and the confidence to be able to have less bounding boxes, because we observed that we have more overlap of bounding boxes of the patient. So we did that and we obtained these results after testing again with the same best model. So I will now hand over to my colleague to tell us more about how we use other models to improve our classification.
So in here, okay, we were having this confusion metrics, like we were having more false positives and a little bit less false negatives. So what we decided, we can reduce false negatives to have more detections in our image. So we can just reduce our confidence level, and we also have to decrease this false positives. So then we decided to go for a strong classifier. So we got, till here we were getting the detections with the low confidence threshold. So after that we probed the neighborhood of these lesions to get a more contextual information, and then we use a vision transformer, because it uses the attention layers, and it gives it aggregates the features from the lesion, it gets more contextual information, and then it will help us to classify it. So for this vision transformer, we had detection data. We almost had 8.5K trained images, so we converted that to classification data, and through these bounding boxes and having a neighborhood of those lesions, we converted this to about 29,000 lesions. And for non-lesions, we had about 6,000 images, and then we applied augmentation and got 18K images. So our VIP helped us to classify these neighborhood growth ROIs. So First with the YOLO, the best model, we were getting around 67.02, and then when we added that VIT in our pipeline, we received like almost 1% increase in our MAP. And when this model was tested on the second half of our data, so it was like we got stabilized results. Yeah, that's it from our side. We would like to thank the organizers to organize this event, because we